Here's the lecture on control of organ blood flow and blood pressure. During this lecture, I need to cover the intrinsic and extrinsic control of organ blood flow and the regulation of systemic arterial blood pressure, both in the short term and the long term. Finally, we need to cover the effects of exercise on blood pressure and on organ blood flow and its control. Intrinsic or local control of organ blood flow is maintained in several methods. The first is something called active hyperemia. This is where you've got increased blood flow during increased metabolic activity, for example, skeletal muscle during exercise. The increase in metabolic activity of the organ leads to a decrease in oxygen within that locality, so within the tissue fluid, the interstitium around that particular organ. You see an increase in metabolites and an increase in temperature generation as well, again local to that organ. All of these result in dilation of capillary resistance vessels, so the arterioles coming into the capillaries, which results in an increase in the blood flow to that organ. All this is the result of that increased metabolic demand for that organ, for oxygen and for nutrients. The second method is flow autoregulation, which is the ability of an organ to maintain constant blood flow despite changes in perfusion pressure. In this situation, it's an example where your arterial pressure in the organ drops. An arterial pressure dropping means that there's a decreased blood flow to that organ, so again, the net result of this is a decrease in oxygen concentration and an increase in metabolites locally to that organ. Again, this results in local dilation of resistance vessels and restoration of blood flow towards normal. Working in parallel to the intrinsic control, we also have extrinsic factors controlling organ blood flow. For example, with the autonomic nervous system, the sympathetic nerves, when stimulated, act as vasoconstrictors. Noradrenaline, norepinephrine have the same result, and alpha-adrenergic receptors on smooth muscle will respond to stimulation, again causing vasoconstriction. This is a method by which we have baseline sympathetic vasoconstrictor tone in many organs. By tone, we're referring to not how tone something is, but the base level of tension that's maintained in that organ to allow it to hold its shape. If you look at this diagram to the side showing a classic artery diagram, the lumen in the middle with the endothelium, basement membrane, and smooth muscle, and then the tunica externa on the outside. It's the contraction of the smooth muscle that results in vasoconstriction. The parasympathetic nerves, however, have very little important innervation of the arterioles, so there's no direct opposite to the sympathetic stimulation here. In addition, hormones exert significant control of organ blood flow. A good example here is adrenaline, which is released from the adrenal medulla by sympathetic stimulation. Adrenaline is a vasoconstrictor in the majority of vascular beds as a result of the alpha-adrenergic receptors present on smooth muscle. However, in skeletal muscle, its effect is more as a vasodilator, and this is the result of beta-2 adrenergic receptors on the smooth muscle. Angiotensin II is an effective vasoconstrictor and is key in the renin and angiotensin system, which we'll cover when we do about the kidney. Vasopressin is another useful hormone, again vasoconstrictor, and this has been produced by the posterior pituitary. If you need to revise the posterior pituitary, have a look through the hormone notes we did in cycle 1. Finally, atrial natriuretic peptide is involved with hormones, but in this case, contrary to the other three, atrial natriuretic peptide is a vasodilator. Hormones are not the only vasoactive agents, however. Other agents include things like ions, such as potassium and protons, oxygen and carbon dioxide, osmolarity of the blood, the presence of adenosine or eicosanoids, such as prostaglandins and prostacyclin. The pro-inflammatory molecule bradykinin or endothelin-1 will also have an effect on smooth muscle and the endothelium in the vasculature to increase blood flow. Many substances act directly on the vascular smooth muscle, however there are several that act indirectly and actually have their effect via the vascular endothelium. A classic example of this is endothelium-derived relaxing factor, or EDRF, which we now know to be nitric oxide. Nitric oxide is an extremely potent vasodilator. Reminding you from some of the material we did earlier on in the CVS set, mean arterial pressure is cardiac output multiplied by total peripheral resistance. remember that cardiac output is stroke volume multiplied by heart rate. Again, remembering Starling's law in the heart, stroke volume depends on central venous pressure. All the abbreviations for this equation are shown on this slide. Again, remember that you have various inputs and outputs from the cardiovascular centre in the brain. So, classic examples of input from the higher brain centres, such as the cortex. Sensory receptors, remember again that the key baroreceptors to remember are on the carotid artery and the aortic arch. And then you have outputs from the cardiovascular centre, such as the accelerator nerves, the sympathetic system, and the vagus nerve of the parasympathetic system. The arterial baroreceptors mentioned are in the internal carotid arteries. This is the carotid sinus baroreceptor and measures high blood pressure, so it will detect an increase in blood pressure coming from the heart going up into the brain. Conversely, the aortic arch baroreceptor detects low blood pressure, so a drop in blood pressure coming out of the heart. We have something called the baroreceptor reflex, which is a potent negative feedback loop to control blood pressure in the short term. So if we assume a normal resting value for mean arterial pressure of around about 80 millimeters of mercury, you can work out roughly where your baroreceptor action potential frequency will lie. As mean arterial pressure increases, so does the baroreceptor action potential frequency. A good example of why we need this is postural hypertension. This is the example where the afferent limb is involved. So sitting to standing, naturally blood will flow into the legs under the effect of gravity. This means we see a drop in central venous pressure and a drop in the end diastolic volume, so the amount of blood that remains in the ventricles once the heart is relaxed. That means there's a lower amount of blood to eject from the heart, so a decreased stroke volume, which leads to a decrease in cardiac output. A decrease in the output means that the mean arterial pressure will also drop, and we'll see a decrease in baroreceptor firing. The efferent limb, however, is mainly involved with the cardiovascular centres and decreased parasympathetic activity. So an increase in heart rate leads to an increase in sympathetic activity. That then follows to an increased arteriolar constriction, so the vessels are getting narrower. Together that increases the total peripheral resistance. We get an increase in venoconstriction and an increase in central venous pressure. That means that our end diastolic pressure has increased, and that means an increase in stroke volume, but together, along with Starling's law of the heart, and remembering that increase in ionotropy to the preload, you have an increased cardiac contractility, which again increases the stroke volume. So depending on whether you're going from sitting to standing, having a drop in blood pressure, which results then in your brain telling your heart it needs to pump harder and faster to get that blood back up into your head, or whether you go on the efferent limb and you have a decrease in the parasympathetic activity, the end result is always to increase that stroke volume and maintain a standard blood pressure. The Valsalva manoeuvre is a frequently used method of attempting to diagnose the condition of the heart or to evaluate the condition of the heart in patients. It's when you attempt to forcibly exhale while keeping your mouth and nose closed. It's sometimes done as a treatment to correct an abnormal heart rhythm or to relieve chest pain. Ultimately, what it's doing is increasing the pressure in the thoracic cavity. That means that you're increasing the pressure on the heart, so you're going to decrease cardiac output. That leads to a fall in mean arterial pressure. The baroreceptor reflex kicks in, meaning that your heart rate is increased and vasoconstriction occurs, which increases your diastolic blood pressure. When you release the pressure by allowing yourself to exhale normally, you have an increased cardiac output, leading to an overshoot in the mean arterial pressure and a reduced heart rate. This is what actually doing the Valsalva manoeuvre looks like when you look at blood pressure or mean blood pressure over time. On the left is a healthy subject, so they're breathing perfectly normally, and at the point where it says strain, that's where they're pinching their nose, closing their mouth and trying to exhale hard. As you can see, you see a drop in the blood pressure. The mean blood pressure also shows that drop because we're now showing it without all the various peaks and troughs. You have an early phase and a late phase. Phase 3 is the point where you've released the strain. and phase 4 is where everything returns to normal, so you have at this point had an overshoot in mean blood pressure. If you look to the right, this is a subject with severe sympathetic failure, so their sympathetic nerves are not working. They're not stimulating that muscle to contract more, they're failing to stimulate the heart. At the point where they're adding strain, the first thing you should note is the blood pressure is much, much higher to start with. It's 130 compared to around about 70 in the healthy subject. The point where you add strain in, so you're causing that patient to try and exhale hard, you can see a dramatic drop in the blood pressure. It absolutely plummets through the early phase, and instead of coming back up steadily in the late phase, it continues to drop. When that patient then releases the strain and breathes normally again, instead of having the overshoot in stage 4 that we saw in the healthy subject, you see a gradual increase back up to where it was originally. This particular figure has been modified from the paper in neurology. You don't need to find it. All the information you need is contained on this slide. So that's short-term regulation of your mean arterial blood pressure. Long-term regulation is more complicated. The baroreceptors will adapt to prolonged changes in blood pressure, so you can't actually set the value of long-term blood pressure as any standard mean. Blood volume changes are the single most important determinant for blood pressure in the long term, so dehydration or drinking too many fluids will both change your blood volume and will both change your blood pressure. If you look at the long-term regulation of mean arterial pressure, start first of all at the top with blood volume. If you have an increased blood volume, this will lead to an increase in central venous pressure, an increase in atrial pressure and an increase in end diastolic volume. According to Starling's law of the heart, that will lead to an increase in stroke volume, an increase in cardiac output and an increase in the arterial blood pressure. An increase in the arterial blood pressure will then trigger several different systems, including the renin-angiotensin system, secretion of atrial natriuretic peptide, and increased glomerular filtration within the kidney. Again, we'll come to all of these systems later when we do the kidney. The overall effect of this is to increase urinary loss of sodium and water, which will bring the plasma volume down and have the effect of reducing the blood volume. When we do exercise, we have an increased metabolic demand. That stands to reason because our muscles and the cells of our bodies are respiring more, so they need far more oxygen, far more nutrients. That means you need an increased blood flow to the exercising muscles. Note not the digestive tract. The reason you're advised not to eat when you exercise or before exercising is because the blood is diverted straight to the exercising muscles, to the heart and the lungs, and it's diverted away from your digestive tract. Secondary to this increased metabolic demand, the increased work means you have an increased heat production. That heat has to go somewhere, so you have increased vasodilation in the vessels close to the skin. That increases the blood flow to the skin and allows the heat to radiate out to the blood. It's also why you go very red. You see an increased cardiac output. To give you an example, if your resting cardiac output is 5 litres per minute, with strenuous exercise such as running or rapid cycling, this can increase to 25 litres per minute. So it's a 5-fold increase in the blood flow. I mentioned about the redistribution of blood flow during exercise. This is a very old table that still shows exactly what I want it to show. So if you look first of all at the leg muscles, at rest you've got flow of around about 0.5 of a litre per minute. And the cardiac output is roughly 9% of cardiac output is going to the leg muscles. When you're doing a leg exercise, so this could be walking on a treadmill or running on a treadmill, that flow in litres per minute to the muscle increases to 3.9 litres per minute, and the percentage of cardiac output going to the leg muscles is 36%. That's a huge increase. If you look at the heart, you have an increase of 0.25 litres per minute to 0.35 litres per minute, and that corresponds to a cardiac output between 4% at rest, 3% at exercise, with leg exercise. This means you've got a very slight increase, but it's not significant. Your heart is still going to be working regardless of what exercise you're doing, and it's still going to need roughly the same amount of blood flow. There is a slight increase because its oxygen demand has gone up slightly. If you look at the skin, you go from 0.5 litres per minute to 1.5 litres per minute. Principally, this is to get rid of excess heat that's been produced. So cardiac output goes from 9% to 14%. The brain remains exactly the same. It always needs around about 0.75 litres per minute flow. In exercise, however, if you're doing extensive exercise, your cardiac output will drop from 13% to the brain to 7%. So although the actual flow rate remains the same, the percentage of the cardiac output that goes to the brain has decreased almost by 50%. At this point, you're now moving over towards the digestive organs. So blood flow to the spleen, Slanchnick area, has gone from 1.4 litres per minute to 1.1 litres per minute. And we're seeing a significant drop again in the cardiac output from 24% of the cardiac output coming to this area to 10%. So it's more than halved. For the kidneys, we've gone from 1.1 litres per minute to 0.9 litres per minute. And again, the percentage of the cardiac output going to the kidneys has dropped from 19% at rest to 8% at exercise, so a dramatic decrease. In active muscle, you see a slight drop in the flow rate of 0.7 litres per minute to 0.6. Actually, you see a slight increase in the percentage of the cardiac output coming to the muscle, but it's not significant. Probably the biggest jump is in the lungs after the leg muscles, where you've gone from 5.8 litres per minute flow, almost doubling to 10.8 litres. We haven't measured the cardiac output going to the lungs. You don't need to know that. The information I need you to take from this particular slide isn't the numbers so much, it's what's actually happening, so that we see a dramatic increase in flow rate to the leg muscles and the skin, but you see a drop in the kidneys and the spleen, so the digestive and filtering parts of your body. It's a well-known fact that if you exercise regularly, you will train, and that means you'll get stronger, your heart will become more efficient, your muscles will become more efficient. It's one of the reasons why long-distance runners train so long, but tend to have very little body fat. They don't need it. They've basically used it all up, and they're maintaining fairly consistent rate of work for the heart, both at rest, but they can call on it when they're doing exercise. If you look at the top chart here, we've got work rate against cardiac output in litres per minute. So for somebody who is untrained, which is the blue line, you can reach a certain point before cardiac output levels off, so in this case around about 20 litres per minute. In someone who is trained, better trained, they can continue to increase that further to around about 25 litres per minute in this example. So that's showing that the heart has actually adapted and is now capable of a higher cardiac output compared to when that person wasn't trained. If you look down to the heart rate in beats per minute, which is the middle curve, again by work rate, you'll see for the person who is untrained, a fairly standard increase in the work rate leads to a standard increase in the heart rate in beats per minute. The person who is well trained, however, for any given work rate, their heart rate is lower. In effect, what this is showing is that the heart does not need to beat as rapidly to get the same amount of oxygen to the cells, the same amount of cardiac output. The final graph on this slide shows stroke volume in millilitres, again by work rate. And again, if you look at the untrained curve here against the trained curve, you'll see that for any given work rate, the stroke volume is significantly higher in the individual that is trained versus the untrained individual. So you can look here at untrained and trained subjects, but what we're effectively looking at is the work rate being done by the heart and the effectiveness of that heart. So the heart rate has increased, but to a lesser extent. So when you're trained, the heart beats stronger, beats more efficiently, stroke volume and cardiac output are significantly greater for any given work rate, and your heart rate is slower for any given work rate. So the heart has become far more efficient. That's the effect of exercise on the heart itself. So if we look at arterial blood pressure, we can look at diastolic pressure, which is pressure in the heart at the end of the heartbeat, remember. This reflects the resistance of the peripheral vascular beds. In strenuous exercise, this will fall. However, if you have mild or moderate exercise, it could remain unchanged, it could fall, or it could increase. You do not need to understand why, you just need to know that that's what happens. Your pulse pressure reflects your stroke volume, and this will always increase with exercise. As with systolic pressure, if you remember that diastolic pressure plus pulse pressure equals systolic, it will increase with exercise. When we're doing exercise, we need to have a mechanism of controlling the cardiovascular system. So we need to increase the cardiac output and redistribute the blood flow, which we've already covered and has shown how that's happened. You can intrinsically control the blood flow, or you can use extrinsic control. So you have feedback control, for example, exercising muscles, informing you that they need a higher level of oxygen, so you've had the intrinsic pathways, and you have the feed-forward control from the brain exercise centres, which actually control what's happening with the heart directly through the sympathetic nervous system. If you need any additional help, as always, please contact me, and it's easier to contact me by email.